Yeah.
Okay, well, it's 8 o'clock, so we'll get started. Today will be hopefully a great instructional grand rounds on how not to get rheumatoid arthritis. And to introduce Dr. Shelef is Dr. Christy Bartles.
Well, thank you. It is my absolute pleasure and privilege to introduce Dr. Miriam Shelef, who is an exceptional associate professor in the Division of Rheumatology. Dr. Shelef earned her bachelor's degree at University of Pennsylvania, which she shares in common with Dr. Shelef, with Dr. Schnapp. And she received her MD and PhD in immunology from Columbia University. She also completed the IMPACT research pathway, completing both the internal medicine residency program and rheumatology fellowship here at University of Wisconsin. In 2010, Miriam received the American College of Rheumatology Distinguished Fellow Award, which is a very prestigious award. And we were fortunate that she joined us on faculty in 2011. Dr. Shelef's lab uses animal models and biological materials from human subjects to study inflammation and autoimmunity with a focus on autoantibodies and citrullination. She's a founder and the director of the UW Rheumatology Biorepository with over 700 specimens, and she has also recently founded and directs the UW COVID Convalescent Biorepository with many collaborators on campus. Shelef has been invited to present her research at many national and international conferences, and this includes a recent invited international expert presentation at the 2020 ACR conference, where she highlighted her seminal work evaluating the overlapping roles between citrullination and rheumatoid factor in RA. She co-chairs the RA animal model section for the ACR annual meeting as well. She has over 35 peer-reviewed publications that have been cited over 5,000 times. She's mentored over 30 learners, and she's been nominated for multiple mentoring awards. She's on the editorial board for the Frontiers in Immunology, and she's been an invited grant reviewer both nationally and internationally, including the UK Medical Research Foundation. Shelef currently chairs the Rheumatology Research Foundation Future Physician Scientist Study Section as well. Her own research has been funded by the Rheumatology Research Foundation, the Doris Duke Charitable Trust, the NIAMS, the Wisconsin Partnership Program, and the congressionally directed Medical Research Program. So with that, it is my absolute honor to introduce Dr. Miriam Shelef to offer a glimpse toward a future state in our field, hopefully, and in her presentation titled, How Not to Get Rheumatoid Arthritis. Thank you, Miriam.
Thanks so much, Christy, for that really nice introduction. So hopefully I can live up to that. And it's not letting me advance my slides anymore.
Just
there we go. Okay, got it. Perfect. All right. Sorry, let me just minimize this thing at the top here. Okay, perfect. So how not to get rheumatoid arthritis. That is our topic for today. I have no disclosures. And these are our 3 learning objectives. So as a result of this program, you should be able to identify the hardships caused by rheumatoid arthritis on affected individuals in society, describe key features of rheumatoid arthritis, and recognize modifiable and non-modifiable risk factors of rheumatoid arthritis. And we're going to use some basic science to gain a better understanding in these areas. So the general outline of the talk is we'll spend part of our time talking about rheumatoid arthritis, or RA. We'll talk about what it is, the costs involved, how we diagnose it, and how it's treated. And then we're going to switch over to how not to get rheumatoid arthritis. So what is rheumatoid arthritis? I imagine the majority of this crowd has at least a general idea. So rheumatoid arthritis is a polyarticular arthritis that involves joint pain and swelling. Unfortunately, many of our patients with rheumatoid arthritis develop erosions as well as destruction in the joint, as you can see here in this X-ray. Most of our patients also have significant morning stiffness, more than 30 minutes, and that's part of what happens in the inflammatory arthritises. But rheumatoid arthritis is not just a joint disease, it's a systemic autoimmune disease, and it can affect many different organ systems. Very commonly, our patients get rheumatoid nodules. Less commonly, we can see pericarditis, pleuritis, Stelte's syndrome, dry eyes and dry mouth. Actually, that's fairly common as well. Cutaneous vasculitis, scleritis, episcleritis, and rheumatoid lung disease. And there's additional manifestations as well, and this is basically just to point out that it's not just a joint disease. So some numbers for rheumatoid arthritis, the prevalence of rheumatoid arthritis is about 0.5 to 1% of the population. So not as prevalent as diabetes, but certainly prevalent enough that everyone in this room is going to know someone with rheumatoid arthritis. When we think about the cost, this can be hard to quantify, but a couple of studies did a nice job. There was a study of annual US societal costs in 2005 dollars for RA, and that's $8.4 billion in excess healthcare costs alone, and 39 billion in total costs. And so that includes healthcare, loss of work, quality of life, early mortality. And then there was a study in Europe that looked at the cost per RA patient. And so they divided it by difficult to treat and not difficult to treat. So difficult to treat RA would cost about $45,000 a year, and not difficult to treat about $23,000. And the main costs were help from family and friends, medications, and loss of work. So really significant impacts financially from rheumatoid arthritis. And then, of course, personally, there's tremendous impact. So rheumatoid arthritis is not a curable disease. If someone gets rheumatoid arthritis, they basically now have a lifelong relationship with their local rheumatologist. And we're a nice bunch, but I suspect that most of our patients would prefer not to see us regularly. People have lifelong immune suppression. It's pretty rare that we're able to totally get rid of the immunosuppressing medications. And even when we immunosuppress people, there's really a strong possibility of at least some residual disease activity. And also increased mortality, especially via cardiovascular disease. So a lot of problems, people have when they have rheumatoid arthritis. So how do we diagnose rheumatoid arthritis? So these are the ACR 2010 diagnostic criteria, ACR EULAR. Those are our two organizations in the US and Europe. And so we don't use these in the clinic per se for every single patient. These are a bit more for scientific research, but they still point out the main points about what we think about when we're diagnosing rheumatoid arthritis. So in order to have rheumatoid arthritis, you need to have at least one tender and swollen joint. So that would be synovitis in at least one joint that can't be better explained by something else. And then once you have at least one joint swollen, then there's a point system like many diseases, and you need at least 6 points for what's considered a definite rheumatoid arthritis diagnosis. So you can see here you get a lot of points for having a lot of swollen joints. And that makes sense, right? Because we talked about this being a polyarticular arthritis. You also get points, there we go. You also get points for having specific autoimmune antibodies that are associated with rheumatoid arthritis, rheumatoid factor and the CCP antibody, which we'll talk a bit more about. And you get fewer points for having elevated acute phase reactants, right? Because those are not specific. And then you get a point if it's been greater than 6 weeks. And the reason for that is because some viruses can cause a form of arthritis that should be gone certainly within 6 weeks. So let's dig in a little bit more to the tender and swollen joints. So here's a diagram of what joints tend to be involved with rheumatoid arthritis. So the small joints of the hands and feet, including wrists and ankles, are really commonly involved in rheumatoid arthritis. But really any of the peripheral joints could be involved without really any surprise. The back tends not to be involved with the exception of a couple of the joints all the way at the top of the cervical spine, and even that's pretty uncommon. So low back pain is not going to be a rheumatoid arthritis symptom. The interesting thing in rheumatoid arthritis is that the DIP joints tend to be spared. We don't know why, but that can actually be really helpful because in osteoarthritis, which is tremendously common, those joints tend not to be spared. And I have pictures here of Heberden's nodes. So patients who have this kind of bony enlargement, sometimes with soft tissue swelling, that would not be a classic sign of rheumatoid arthritis. So that's really helpful for diagnosis. So if we take a closer look at what's going on inside the joint, so this is a diagram of the knee joint, and you can see the bones and you can see the cartilage on the surface. You can also see the synovial lining here with the synovial fibroblasts at the ends. In early rheumatoid arthritis, we start to see an influx of immune cells. it can really be just about any type of immune cell. In particular, there's often a lot of macrophages, and this diagram doesn't happen to have macrophages. The synovial lining also becomes larger. There's increased proliferation, reduced cell death, and ultimately, as arthritis progresses, the synovium becomes what we call a pannus, which actually looks very much like a tumor. It grows its own vasculature, and it is also filled with lots of immune cells. It does not have the genetic instability of a tumor, however. This pannus can then invade the cartilage and bone. There are osteoclasts that also get recruited in order to degrade the bone. And of course, these immune cells can all be very destructive as well. So coming back to our diagnosis and our categories here, we talked a bit about the joints. Now I'd like to focus a little bit on the autoimmune antibodies, and we're going to take a little bit of a deeper dive into pathophysiology here. So there's two different types of antibodies that we really think about in rheumatoid arthritis. So one are these anti-citrulinated protein antibodies, and these are antibodies that bind to proteins in which the arginines have been converted to citrulline by a family of enzymes called the peptidyl arginine deaminases, or Ppad enzymes. So we call these AKBas, these anti-citrulinated protein antibodies, and they're both diagnostic and pathogenic. So the anti-CCP test that we use to clinically diagnose rheumatoid arthritis, what it's basically measuring is the levels of these anti-citrulinated protein antibodies. And the test is pretty good. It's about 67% sensitive, so you don't catch everybody. We have lots of seronegative RA, but it is about 95% specific, which is really helpful. So if you're seeing a positive anti-CCP test, it's almost certainly rheumatoid arthritis. These antibodies are also pathogenic. So the anti-citrulinated protein antibodies, they can induce osteoclast formation and bone loss. If they're transferred into mice who have been stimulated to get arthritis, they will make the arthritis worse. And we can also find them in the human joint, and they can activate immune cells, particularly macrophages there. So we've been able to use them for diagnostic purposes, but they're actually pathologic in disease. They're a really interesting type of antibody because one antibody tends to be cross-reactive against many different antigens that have been citrullinated or homocitrulinated, which means that the lysine has been converted to homocitrulline, or antigens that have been acetylated. We don't really know how or why this happens, but there have been a number of studies that have been very interesting, and I'm just showing you one piece of data from one group. And what they did is they purified monoclonal antibodies. So they purified the B lineage cells that were producing antibodies. They grew them up in the dish, and they purified the one antibody that this B lineage cell was making. And then they took that one antibody and they used it to evaluate what that antibody bound with an antigen array. So they put on this antigen array, actually about 170,000 antigens, tiny peptides, just about 12 amino acids long. And those peptides were either the native form or the form in which arginines were replaced by citrulline or lysines were replaced by homocitrulline. And what they saw is that one antibody could bind all these thousands of different homocitrulline containing peptides, citrulline containing peptides, but really didn't bind anything that had an arginine in it or a lysine in it. So this is really interesting for an antibody to bind so many different things. They did find a motif. They found that citrulline next to glycine, or CARP, which is homocitrulline next to glycine, tended to be a motif, but it's not perfect. My group actually did similar studies looking at sera, not purified monoclonal antibodies. We found this motif as well as a similar motif in which the citrulline would be next to a serine. So still some work to do, but very interesting antibodies. So the other type of antibody we see in rheumatoid arthritis is rheumatoid factor. Most of you have heard of this. This is an antibody of any isotype, so an IgM, an IgG, an IgA, or an IgE, that binds to the Fc portion of IgG. So this is a basically stretched out IgG molecule. And so out here we have the variable region, and that's what's going to bind to different antigens. And this is the constant region of the antibody. And this is the part of the antibody that would be the same for every single antibody and what would attach to complement or FC binding molecules on macrophages and other immune cells. And then this portion here that I have outlined is called the FC region. So that's the region we're talking about that rheumatoid factor is binding to. So one of the interesting things about rheumatoid factor is it doesn't just bind up native circulating IgG. And that's good because if it did, then everybody with a positive rheumatoid factor would just bind up all their antibodies in the circulation and then they'd be cleared or even clump. And the reason for that is because this is what antibodies look like in circulation. They're folded over and that FC region is hidden. But that region actually gets revealed when the antibody binds to an antigen. It opens up, and that allows the rheumatoid factor binding. It can also happen with heat or chemical denaturation, including free radicals, which we do see in inflammation. We see it when we absorb the antibody onto a hydrophobic surface, for example, to evaluate for rheumatoid factor in our different assays. Enzyme-mediated degradation can open that up, or aglycosylation, which we do see in inflammation. So rheumatoid factor is not just found in rheumatoid arthritis. It is common in rheumatoid arthritis. It's about 69% sensitive. And most people who have a positive CCP antibody also have a positive rheumatoid factor. Those two tend to go hand in hand. But rheumatoid factor is only about 85% specific. And the reason why is rheumatoid factor rises in some people, about 10 to 20% of people, in response to infection, commonly known in Hep B, Hep C, but it can also be seen in influenza and acute illnesses. We see it even when people are vaccinated. Smoking can induce rheumatoid factor. We see it in hematologic malignancies and also in other autoimmune diseases like Sjogren's syndrome and lupus. So whereas the CCP test is very specific for RA, rheumatoid factor is not. So what's rheumatoid factor doing? And this is a bit of a mystery because there's only been a couple studies that have looked at this, and some of them, as you can see on the bottom, are quite old. They were done many years ago. So what we know is that if you have virus that's bound by IgG, rheumatoid factor can bind to it and enhance neutralization by complement. So that's helpful. It can also enhance the uptake of immune complexes by macrophages to clear them from the circulation. Another interesting thing it can do is if IgG is bound to, say, bacteria, and that bacteria has enzymes that can cleave the IgG, the rheumatoid factor can bind on, like you can see here, and can act like a surrogate FC portion to signal through complement and through macrophage binding. And another really interesting thing that rheumatoid factor can do is the B cells that make rheumatoid factor, they can bind to IgG that's bound to antigen, say a virus. It can take it in, act as an antigen presenting cell, and present that virus to a T cell. So even though this B cell is not specific for the virus, it can help the T cell to have a stronger T cell immune response. So what about in rheumatoid arthritis? Well, rheumatoid factor appears to be pathogenic, mainly with the same sorts of pathways. So we know that when rheumatoid factor binds to those AKBa immune complexes, it can activate complement, and it can also activate macrophages by binding to receptors on the macrophages, leading to cytokine production, the sorts of cytokines we see in rheumatoid arthritis. And we know that rheumatoid factor and active immune complexes can deposit in the joint, so they end up in the pathologic place that you'd expect them to. So the same mechanisms are employed, but in a pathogenic way. But one of the big mysteries has been why people with rheumatoid arthritis make these unusual antibodies that bind to lots of different modified proteins, citrulinated, homocitrulinated, whatnot, as well as rheumatoid factor. And it's not just 10% of them like in other diseases, it's really the bulk of them. And so what's really going on? So there's been a variety of hypotheses. One I call the convergent pathways hypothesis. And in this hypothesis, the idea is that certain features can stimulate the production of rheumatoid factor, such as smoking, and then other other things predisposed to the formation of AKBas, and we'll talk about them later. And what might happen is very similar to that rheumatoid factor producing B cell helping the T cell to make virus. Maybe that's happening to help the T cells make more AKBas. And then those T cells might even be coming back to stimulate some of those B cells that make rheumatoid factor so that these cells can actually stimulate each other to enhance the production of both types of antibodies. And so they kind of feed into each other in these convergent pathways. But another possibility I call the common antigen pathway. And in this, what we think is happening is that IgG becomes modified endogenously, perhaps citrulinated, homocitrulinated. And there is some evidence for that. We've seen it in our lab and other labs have shown it as well. So then if you have a modified IgG and then a cell makes an antibody against, say, citrulinated IgG, you could imagine that through epitope spreading, you could go in one direction towards production of more rheumatoid factor that maybe binds to native peptides, as well as the production of more of these cross-reactive AKBas, all coming from this one common antigen that shares features of each. But in order for that hypothesis to even be considered, you'd have to be able to find these antibodies that bind modified IgG. And this is something that we have done in my lab. So what we did is we used actually a similar array that I showed you earlier, and we put all the different linear peptides of the heavy chain of IgG, IgG 1, 2, 3, and 4, onto this array. And then we evaluated IgG binding to all those different peptides. We used IgG from CCP positive, rheumatoid factor positive RA sera, and we also used control sera. And what we're looking at here in this graph is we're looking at the binding in the RA sera divided by control. The peptides we put on the array were native in black, citrulline containing in red, and homocitrulline containing in blue. And as you can see here, there's very high levels of IgG binding to the homocitrulline containing peptides and the citrulline containing peptides. So we are seeing antibodies that can bind to modified IgG epitopes. We also went on to show that some of those monoclonal AKBas, some of those cross-reactive ones, can actually bind to the same peptides. Not all of the monoclonal AKBas, but some of them can. So that suggests that some of these cross-reactive antibodies could have derived from these anti-IgG antibodies, although we're just guessing a little bit. We just know they both exist at this time. And interestingly, when we look at sera from lupus and Sjogren's syndrome, that only where we don't see the anti-CCP antibodies, that sera only binds to a single native linear IgG peptide. And I should say I neglected to include Sarah McCoy on here. I have two pictures of graduate students in my lab who did a lot of the bench work looking at the antibody binding, but the Sjogren samples come from Sarah McCoy's biorepository in Sjogren's syndrome. So when we put all this together, I'd like to just touch upon the potential intersection between rheumatoid factor and AKBas, because this is a big research interest for me. So, we know that in rheumatoid arthritis, we have lots of rheumatoid factor that binds native IgG. And we know we have lots of different, what we've been calling AMPAs, or anti-modified protein antibodies, which includes the AKBas. So we have those antibodies. And then we have this antibody in between that we now know about, these IgG anti-modified IgG antibodies. And some of them are cross-reactive in this way. And what we don't know is which came first. And that's something that we're starting to work on now in collaboration with other institutions. So we definitely had a big digression to talk about a little basic science and how antibodies come to be in rheumatoid arthritis. So I'm going to pull us back to the clinical world here, because the way we got here is we were looking at serology with rheumatoid factor and CCP. And so we just dug in a little bit to talk about how these serologies develop. But now when we come back to the clinical world and we think about rheumatoid arthritis, it's pretty bad, right? So, Okay, so rheumatoid arthritis is pretty bad. I think I lost a slide there. It's incurable, it has high costs, it has terrible treatment. And I just wanted to touch on some of the treatments we use, just so people have some familiarity. We do use brief courses of prednisone. We tend to use them just when our typical medications are starting to work, because that can take months. And sometimes we use prednisone to treat flares. The first thing we tend to use long-term in rheumatoid arthritis are the non-biologic disease-modifying anti-rheumatic drugs, or the DMARDs. And so these are things like hydroxychloroquine, which is actually not really immunosuppressive, so that's nice. We also have sulfasalazine, leflunomide, methotrexate, all immunosuppressants. And then we move on to the biologics. Sometimes before moving on to the biologics, we'll try something called triple therapy, in which we combine hydroxychloroquine, sulfasalazine, and methotrexate, which does tend to work very well for some patients. But then we move on to the biologic DMARDs. We have our TNF inhibiting medications that inhibit the cytokine TNF alpha, etanercept, adalimumab, infliximab, certolizumab, golimumab. We also have an anti-CD20 antibody, which destroys B cells, and that is called rituximab. And I'll add that we're starting to have some generic antibodies, both TNF inhibitors and rituximab type antibodies. We also have the anti-CD80-86 blocking antibodies. These block T cell stimulation, and the drug is called abatacept. We have the anti-IL-6, which are called tocilizumab and citrullination, and they block IL-6. And then we have the JAK inhibitors. So the JAK molecules are downstream of the cytokine receptor. So if you can block the JAK, then you can block signaling from multiple cytokine receptors. And so far we have tofacitinib, baricitinib, upadacitinib, with plenty more in the pipeline. So I think I've shown you here that rheumatoid arthritis is bad. It's incurable. There's joint pain and destruction, often despite treatment. People have lifelong immunosuppression, increased mortality, and high cost. So if rheumatoid arthritis is so bad, let's switch gears. How can we not get it? And I think you'll see here that much of this is tongue-in-cheek, but we're going to talk about different ways that one could potentially prevent rheumatoid arthritis. And so our topics are: choose your parents well, stay forever young, watch your mouth, or at least what goes into it, don't be intolerant, and consider the glamorous life of a guinea pig. So first, choose your parents well. We'll talk about genetics, sex, race, and ethnicity. So number one, avoid your biological parents' bad genes. So here's a Manhattan plot of some of the genetic variants that are associated with rheumatoid arthritis. And I think what you can probably see here is that HLA-DRB1 has the tallest and thickest line in this Manhattan plot. And it is, in fact, a very strong risk factor that we've known for many years to be associated with rheumatoid arthritis. So HLA-DRB1, as I mentioned, associated with rheumatoid arthritis, and it has alleles that may be high risk or protective, with different alleles associating with RA in different races. And just as a reminder, here's our MHC class 2 locus. We have HLA-DR, DQ, and DP. So here we're talking about HLA-DR, and we're talking about the beta chain. So seems kind of interesting that some alleles could be high risk or protective, and the reason for that is the shared epitope. So the shared epitope is a 5 amino acid sequence in HLA-DRB1. Here it is right here, and it's thought to drive most of RA's genetic susceptibility. It's dose dependent, so if you have 2 different alleles at HLA-DRB1, or even the same allele, and both have the shared epitope, you have a higher risk than if you have one allele. And you can see here that the shared epitope is right in the middle of what binds antigen. So here's a peptide that's being bound by this MHC molecule, and the shared epitope is right here. So you can imagine how that could maybe have an effect on what's happening. And so what we think is that HLA molecules with the shared epitope may do either one of 2 things, or maybe even both, because we have data for both. So one is that these shared epitope containing HLA molecules, they can bind citrulline containing peptides better than arginine containing peptides. And you can see when the citrulline's right here in the middle, that shared epitope had been right here. So it really makes a lot of sense. But another group has shown that Ppad4, and that's that citrulinating enzyme, at least one of them, actually, Ppad4 is bound really well by shared epitope containing HLA molecules. And then that Ppad4 might still be attached to peptides that it recently citrulinated. So the MHC molecule grabs onto the Ppad4, but it ends up presenting the whole thing when it's stimulating T cells. Either way, because of what that MHC molecule is binding, it looks like that's how it's leading to the production of AKBas and ultimately disease. So don't be female. Lifetime risk of developing RA in women, 3.8%, in men, 1.6%. Why? We don't really know. Could be hormones, could be exon activation, could be other things. Can you escape your fate by gender transition? There's not a single article about transgender individuals in RA development. So we really have some work to do there. How about race and ethnicity? Well, here's another tough area. So we know that RA is less common in rural Africans compared to populations of European descent. But that's not really comparing apples to apples. We also know that the Pima people, who are Native Americans who live in the southwest of the United States, they have a very high risk of rheumatoid arthritis. Their age-adjusted incidence is 10 times higher than in Minnesota, where we have a lot of studies out of the Mayo, and 5 times higher than Japan, based on similar studies. So clearly there's some risk in the Pima people. So this is not my area. My area is more disease pathogenesis, but I really couldn't find many articles that looked at race and ethnicity. And even comparing the Pima to other populations, there could be all sorts of factors that are involved there. And so I looked at what some of the experts are saying, and Iris Navarro-Milan and Kevin Yip write, the majority of epidemiologic studies, outcomes, and trials of patients with rheumatoid arthritis included primarily white patients or without racial information defined. And they go on to say there's little population-based data regarding the specific incidence rates and prevalence of rheumatoid arthritis among individuals who are African American or Hispanic. So once again, we really don't know, and we really have work to do. So if we move on, next is stay forever young. So definitely avoid aging. Lots of things happen as we age. So some of our rheumatic diseases are more common as we age and some are not. The mean age of incidence of RA is 55 to 56, depending on the study. And many of those studies are out of Rochester. And looking at this graph, we can see that, say, GCA, sorry, giant cell arteritis or PMR are extremely age-related, both in women and in men. But RA is as well. Not quite as much, but we can see the incidence rising over time. So why would that be? Well, again, we don't fully know, and we don't know what's cause and effect here. So one thought is that it could be something called inflammaging, which is a chronic, sterile, low-grade inflammation that is seen in older adults, and it's correlated with many different age-related diseases. And we think this may be part of what's going on in RA for a lot of reasons. One is the similarities between RA and inflammaging. So they both have increased IL-1 beta, IL-6, TNF-alpha, and IL-8. So RA has a lot more of those cytokines, whereas it's only a little bit more in inflammaging, but still similar pathways. We tend to see autoreactive T cells in both diseases, again, more so in RA than in the other diseases. There are more senescent inflammatory monocytes in both diseases, and both are associated with obesity, which also increases with age. So it's possible with these similar pathways that if someone is going down the road towards rheumatoid arthritis, as they get older and as other things are starting to cause maybe autoreactive T cells and increased cytokines, that kind of tips people over the edge as they age. And those are our theories. So moving on, watch your mouth, or at least what goes into it. So we're going to talk about obesity and alcohol, lung irritants and inflammation, and the microbiome, a very popular area. So avoid obesity. So obesity increases the risk of developing RA, decreases the odds of RA remission, and worsens disease activity and patient-reported outcomes during therapy. So definitely try to avoid obesity. Obviously, easier said than done. It's easier said than done. But then when we think about it, after someone already has arthritis, about weight loss, the data is a little bit tricky. So there's there's some data that weight loss and rheumatoid arthritis would be good, and that makes sense logically. So weight loss more than 5 kilograms is associated with improved RA disease activity in one study. Another study showed that after bariatric surgery weight loss, patients had lower RA disease activity, decreased inflammatory markers, and a reduced need for RA medications. So lots of good things. But there's also a couple studies that show bad things. So among patients with RA who've lost weight, this has been associated with cardiovascular and cancer mortality. And an underweight BMI is associated with respiratory mortality. So how do we put these two things together? What we can probably say is that intentional weight loss is good and unintentional weight loss is bad, which is really what we'd expect to say, but we do need some more studies to really show that clearly. Regardless, as always, you would want to encourage your patients to be at a healthy body weight. So, some good news, drink up, maybe. Well, in Sweden, there's a 37% decrease in RA risk among women who drank more than 4 glasses of alcohol weekly versus less than 1 glass weekly. So this is not a tremendous amount of alcohol. This is within safe limits. It's less than 1 glass a day. And it showed a decreased risk in RA. And in the United States, for every 50 grams per week of alcohol consumption, there's an association with an 8% reduced risk of RA. So some studies don't find any effect, but it looks like the effect is not bad. So drinking in moderation may be helpful in preventing RA. We have no idea why that would be, but sometimes you just have to accept some good news. So don't ever smoke. Pretty much any speaker who ever gets up here will say that. Many studies find that smoking correlates with increased risk of developing RA. In identical twins, ever smoking gives an odds ratio of 12 for developing RA, so pretty significant. So what if you do smoke and you get RA and you stop? Will that be helpful? It might be. The smoking cessation studies have some mixed data, but it looks like smoking may reduce disease activity. But even if it doesn't reduce disease activity, it does seem to reduce the occurrence of the extra-articular RA manifestations, like what I showed you early on, especially the manifestations in the lung. It tends to reduce the occurrence of severe infections, as well as mortality due to cardiopulmonary diseases. So definitely don't start smoking. If you start, stop. And not only that, but be careful what you breathe. So there's an increased risk of RA with exposure to some types of outdoor pollution, cooking fuels, which are not real common in our personal worlds here in Madison, but are more common in other parts of the world. And we've even seen increased risk of RA flare with exposure to air pollutants in the prior 60 days. That's just one study, but I think it's interesting that could even prompt a flare. Avoid upper respiratory tract infections. So this is partly tongue-in-cheek because we don't know what's cause and what's effect. So we know that people who develop RA have more respiratory disease diagnoses. And we also know that in that year preceding their RA diagnosis, there's increased upper respiratory tract infections. And you can see that over here with the controls. And with early RA, there's about twice as many upper respiratory infections in people who developed RA the next year. Cause or effect, we don't know. Could those respiratory infections be triggering the inflammation that leads to RA kind of at the end? Or is it that these people with RA already have a dysregulated immune system and they're not fighting infection as well? And there's some evidence for both. But why is this happening? How could lung irritants lead to RA? So we know that smoking and other causes of inflammation induce citrullination and NETs. So we touched on citrullination earlier when we talked about the antibodies that bind to the citrullinated proteins. And citrullination is just the conversion of arginines in a protein to citrulline, catalyzed by those peptidyl arginine deaminases. So nets, some of you may have heard about nets. These are neutrophil extracellular traps. These are structures formed by activated neutrophils to trap and kill microbes. And they display lots of citrullinated proteins on their surfaces that can be bound by these AKBas. So you can kind of see how everything's tying in. So what happens is if you have a neutrophil that's quietly resting, and here is a picture of its DNA and its nucleus, it becomes activated. The peptidyl arginine deaminases move to the nucleus. They start to citrullinate histones and other proteins. When the histones get citrullinated, then that helps the DNA to decondense, and ultimately that neutrophil basically explodes in this neutrophil extracellular trap, spewing its DNA all over the place, studded with lots of citrullinated protein. So this is very inflammatory and also has some of those antigens that we see in RA. So how do we move from the lung to the joint? Well, we know that citrullination increases with inflammation in general. So you can have those nets form whenever you have citrullination in sepsis, thrombi, all sorts of things. And we see it in the joint too. And so here's just some immunohistochemistry of synovial tissue staining for citrulline. And you can see a lot of the citrulline in brown in the synovial tissue from RA as compared to control. So if you try to put it all together, then you have inflammation, maybe low-level inflammation in the lung, and this leads to the formation of these neutrophil extracellular traps with citrullinated protein. You get an immune response to the citrullinated protein. Here's just shown a B cell, which is ultimately going to mature, become an antibody-secreting plasma cell that lives in the bone marrow. Those antibody-secreting plasma cells are making lots of AKBas. Those might help permeabilize the joint. They're going to enter the joint. If there's any sort of joint inflammation, maybe some minimal trauma, low levels of infection or inflammation for reasons we don't understand, we're going to get more neutrophils, we're going to get antibody deposition, and these two things may even feed back and forth. So as the antibody response grows in the joint and the lung, you can end up getting worse arthritis, maybe even getting worse lung disease, which we see in about 10% of our patients. So all kind of ties in together here. So in addition to the lung, there's also the microbiome to consider. So we want to avoid microbiome dysbiosis. And this dysbiosis associated with RA is found both in the mouth and in the gut. So if we first look in the mouth, there's increases in P. gingivalis, and I'm going to call it AA because it is quite a large bacterial name there. So P. gingivalis and AA are both associated with periodontitis, AA with severe periodontitis. And periodontitis is associated with RA, at least slightly. And periodontitis obviously looks kind of terrible here, but it's a chronic inflammation of the tooth joint. And so I'm calling it the tooth joint kind of loosely because it's inflammation of the tissues around where the tooth inserts, which is very much like a tooth joint. And so one could imagine how this would be similar to RA, potentially similar pathologies. And so what we know is that when P. gingivalis overgrows, this can be associated with RA. People with RA have higher antibody titers to P. gingivalis than controls. And also P. gingivalis has its own citrullinating enzyme called Ppad, and that can citrulinate arginines, and people think that those citrullinated arginines with all the inflammation from the periodontitis can lead to the formation of AKBas and ultimately RA. But you could also imagine a reverse scenario where people with RA have AKBas, and if the P. gingivalis is citrulinating proteins in the gums, that could lead to destruction similar to RA. And similar story with the Agricobacter. So people with RA have higher antibody titers to that AA leukotoxin A than controls. And we know that AA can hyperactivate pads in host neutrophils because leukotoxin A can create pores that allow calcium to come in to activate hypercitrulination. And so then same story, if you've got this hypercitrulination, then you could imagine how AKBas could form. So we can actually add this to our model so that we've got citrullination and inflammation in the mouth, in the lungs, in the joint that all might be feeding each other, and it's a little bit hard to tell what comes first. So moving on to the gut and avoiding microbiome dysbiosis in the gut, I just want to look a little more closely to the increased Prevotella and the decreased Bacteroides that's seen in RA. There's a very nice experiment in which the investigators took germ-free mice that are arthritis prone, these SKG mice, and they took feces from RA patients or controls, and they colonized the mice with these feces. And so the mice became colonized with the high level of Prevotella, low level of Bacteroides, or vice versa, depending which feces they got. And then they induced arthritis with low-dose zymosine, which is a fungal element, which is how you typically induce arthritis in these mice. And you can see here that the mice that got the RA feces had much worse arthritis than the control mice when they look at arthritis score, which typically involves swelling and strength, ankle thickness, and here when we look at histology and the RA versus control. So this suggests that those bacteria are actually pathogenic. When you add them, they can actually make the arthritis worse. So whereas a lot of the things I've shown you are unclear what's cause and what's effect, this pretty clearly looks causal. So all these things have been happening in individuals, and the next step I would say is don't be intolerant. And here we're going to talk about loss of immune tolerance, autoantibodies, and cytokines. So as these things have been happening over the years, genetic susceptibility, citrullination, different insults to the lung, to the gut, what ends up happening is people develop these autoimmune antibodies, which we talked about earlier in the talk. They start developing anti-CCP antibodies first, and then rheumatoid factor. And this has been shown in a couple studies very nicely, but this study has a nice graphic. And you can see that decades before people develop symptoms, they already have antibodies. And this is part of why if we have someone with seronegative arthritis, we don't usually keep checking antibodies because these antibodies should be present long before a disease starts if someone's going to have them. Also, before rheumatoid arthritis develops, cytokines start to rise. So once cytokines start rising, it's this inflammatory milieu, and it's kind of hard to stop things. So definitely don't want to get those antibodies or the cytokines rising. And in this study, they looked at multiple different cytokines and chemokines involved with rheumatoid arthritis, and they saw that, again, decades before disease, you start to see cytokines, but really they didn't see a significant divergence between RA and controls until about 7 years before arthritis diagnosis. But still 7 years is a long time before arthritis diagnosis to have this preclinical RA. And it's possible that this altered cytokine milieu could be predisposing to these respiratory infections, or the respiratory infections could kind of tip people over the edge and they end up getting full-blown rheumatoid arthritis. Okay, so you got your parents' bad genes, you kept getting older, your microbiome got dysregulated, maybe you smoked, you've got environmental pathogens. Unfortunately, your immune system became intolerant. You've already got the antibodies. What do? Well, my last piece of advice is consider the glamorous life of a guinea pig. And by that, I mean consider an RA prevention clinical trial. And there is one going on in the US right now, Strategy to Prevent the Onset of Clinically Apparent Rheumatoid Arthritis, or STOP RA. It's the first clinical prevention trial for RA in the United States. And what they're doing is they're recruiting 200 healthy individuals who have that CCP antibody. So potentially having preclinical RA, but don't have any clinical disease. Everybody gets a joint exam. Then they randomly treat them with either hydroxychloroquine or placebo. As I mentioned earlier, hydroxychloroquine is one of the DMARDs that we use, but is not particularly immunosuppressive. I like to think of it as immunomodulatory, even though we don't really know its full mechanism of action. Primary outcome is number of subjects with clinical RA by month 36. And this is currently enrolling across the USA, all across the country. Estimated completion date, November 2023. So stay tuned for that. So to summarize, RA is an incurable disease with pain, disability, increased mortality, and high cost. There are both modifiable and modifiable risk factors that contribute to RA, but there's still many mysteries and many problems that we haven't sorted out yet. And so we need scientists to learn more and to develop new treatments and cures. And so I thought I'd end this slide with my team of scientists. These are the people in my lab, including myself, and we are trying to solve some of these mysteries. So I can thank you for your attention. I don't usually get to talk this long, and I'm happy to answer any questions.
Great. Well, thank you, Miriam, for a wonderful overview of the biology and epidemiology of rheumatoid arthritis. The first question, see if we can open up the mic for Amy Kind.
Mic is open.
Well, if Amy's not near a mic, her question is, first of all, wonderful presentation. Is there any data on how the exposome or other social factors may impact rheumatoid arthritis incidence? And in particular, since race is primarily a social construct, not a biological construct, could some of these other factors underlie the observed race association via an epigenetic mechanism, et cetera?
Yeah, so that's a great question. There is not much out there. I feel like I should almost turn the microphone over to Christy, who knows a lot more about this than I do, not being an epidemiologist. But I am not aware of too much that is known in that area, which is not surprising since we haven't even figured out the question related to race.
Okay. Is there any data? Oh, Christy, do you want to add anything?
I was just going to say, I think Miriam also highlighted two things that I'll just bring us back to, because Miriam did a nice job highlighting that. I think like the air pollutant question and the smoking question would be some of the other environmental exposures that obviously are also disproportionately burdens borne by people in low socioeconomic status, or perhaps the Pima Indians may have more environmental smoke exposure, or those indoor cooking pollutants or things like this that you mentioned, Miriam. So you really hit on a few things that could be investigated further. So your talk was great, highlighted many of those mechanisms.
Great. Is there any data about exercise and prevention in rheumatoid arthritis?
That's a good question. I didn't find much, but I also didn't look specifically. Boy, you guys are into the epi here. You're kind of killing me. There's definitely some data for exercise and bone strength, but I don't know of much for arthritis protection.
Well, I'm going to ask my question, sort of combined with Alan Bridges' question. So I was very interested in your common antigen hypothesis, and if you believe that you should be able to see a progression of antibody profile over time in patients who are developing rheumatoid or at risk for RF. And so have you looked at that? And do you hypothesize that the antigen of rheumatoid factor is the if I can pronounce it right, citrullinate IgG?
So I have two answers to that question. So one, this is something that we're interested in looking at. And so we've actually been working with Kevin Dean at the University of Colorado in Denver and his colleagues who have a preclinical RA and an early RA cohort where they track people prospectively, and they also have samples retrospectively after people have developed RA. And they actually published some of the studies looking at antibody development prior to clinical RA. And so we're going to work with them to try to see which antibodies we can see first, because they often have multiple samples from people. So that's our next steps. What I showed you in that one slide is actually not even published yet. We're submitting it now. So now our next step is moving on. But then as far as do I really believe that's the common antigen, I think that that's part of the answer, because, and I'm sorry, I'm hearing a lot of feedback. I don't know if this is my fault or... And oh, there's that. Okay, so I think it's probably part of the answer because rheumatoid factor, of course, is a little bit more complex than I presented in this kind of overview. And a lot of rheumatoid factor is IgM that binds to the Fc portion of IgG. And I think that IgM is not going to have come from these citrulinated epitopes because we know that smoking itself can induce that IgM. And so I think that it's going to be part of the answer, but I think that in being part of the answer, it's why we see this correlation with CCP. So we see a little bit of rheumatoid factor in lots of different diseases, but we see a lot of rheumatoid factor in RA. And so I think it might help explain why we see so much rheumatoid factor in RA.
Okay. Okay, and I think Lauren has a question next. Let's see if this will work.
Okay, should I read it out? So thanks, Miriam, for a very elegant talk. Stop RA trial sounds interesting, but also as a drug study. Are there any trials for lifestyle modification in the literature or planned for the future? Not that I've seen. There have been some diet studies that have been done, but I don't think any are open right now.
And Miriam, we lost your video.
Yeah, you did, didn't you?
That was my fault as I'm trying to unshare slides.
There you are.
Okay,
Nice.
perfect. I got myself back.
Okay. Are there other upcoming clinical trials for RA, either prevention or treatment that are coming down the road?
So there's always trials for treatment. Various things are always coming up. I don't know of any other prevention trials that are coming up though. In part because it's hard to identify these people, right? We don't normally check a CCP. Sometimes people use first-degree relatives who are at higher risk, but it can be hard to really identify who's at risk.
All right. Well, I want to thank you really for a wonderfully elegant walkthrough for rheumatoid arthritis. I love the guinea pig picture personally, and it'd be great to get more of our patients enrolled in some of these national clinical trials, and look forward to the next progression in your research story. It sounds very exciting. So thank you so much.
Thank you.
All right, take care. Bye-bye.
Bye.